you say, a very warm welcome to everybody for this fantastic happy hour. If this is your first time that you've joined our happy hour, these are our regular webinars that normally take place on a Tuesday afternoon. In fact, I think this one is our 145th since we commenced our series of webinar programs. And as you say, Jerome, this is very much a partnership approach with the Royal College of Occupational Therapy and Foundations and our sponsors, TOTS, the Occupational Therapy Service, and supported by Vivenza and the SHAPE programme, Suitable Housing for an Ageing Population. A number of the people speaking today will know that I've been sort of very keen to get a happy hour based on the recent publication from the College and Foundation, Building Health into Housing. And I was privileged to attend the launch at the House of Lords only recently. And I'm not going to spoil any of their thunder, because what we're going to hear today is very much the resources that have been published subsequently, the engagement that's taken place across the sector, and also a better understanding about what it means in practice. So it's not just about the policy landscape, which is important, but also very much around delivery and the tools that are around to support the delivery. Because as we all know, adapting and improving our existing stock is important as accessible housing new build as well. We need to make sure that we can support people age in place across the sector. So thank you very much for all our speakers in advance this afternoon. We're going to kick off with Lauren Walker. She's the Professional Practice Manager at the Royal College of Occupational Therapists, and indeed is also on the advisory board of our SHAPE programme. Lauren, thank you very much. She'll be followed by Dr. Rachel Russell, Head of the Regional Advice at Foundations, and we're also joined by Chris Pratt from Foundations, but Rachel will take the helm, if I can say it that way. And Rachel's worked closely with the LIN over many years, and in fact was one of our co-authors for Adaptations Without Delay back in the day, so thank you very much. And Lucy, we're really delighted that you and the Occupational Therapy Service can be with us, because actually you're going to also share, based on your recent blog for the Housing Then, why this is important for delivery and improving the outcomes for older and disabled homeowners. We'll then have a short Q&A session before we draw this session to a close and thank everybody for their participation. So Lauren, without further ado, can I hand over to you?
You certainly can. Thanks ever so much, Jeremy. Yeah, good afternoon, everyone. I'm Lauren. I'm the Professional Practice Manager at RCOT and very proudly an occupational therapist myself by background. I'm going to start showing my slides, but while I do that, I just want to say thank you to Jeremy and to Jerome and colleagues at Housing Lynn for your unwavering support of our profession. We've had a very long and fruitful collaborative relationship between Housing Lynn and RCOT. Obviously, one of the highlights of that was the development of Adaptations Without Delay. And what I would say before I really launch into my presentation, if my computer decides it wants to play ball, is that Building Health into Homes, I would say, it has evolved from Adaptations Without Delay, but it's absolutely not more of the same. I would say that it hasn't superseded Adaptations Without Delay. These new resources very much travel alongside and are building on some of what we've learned through developing and that process and talking to teams who've put Adaptations Without Delay into practice. But this is something really, really very new. So my job over the next 10 minutes is to really, I think, tell you the why about this project. So why have we chosen to create the resources that we've created, and why now? What I will say as well is that it has very much been a team effort. Jeremy, you said that this has been a collaboration, and that's absolutely true. So although the resources are RCOT products, we've worked hand in glove with our friends at Foundations on this. We had sponsorship from COSAMAT as well, which has really enabled us to think very broadly about the scope of what we've created. But there's been many people who've touched this project in some way. So Jeremy was part of our steering group alongside quite a broad range of colleagues from health, social care, housing, occupational therapy and non-clinical backgrounds. And Rachel and the team at Foundations have had conversations with goodness knows how many occupational therapists through the process of developing these resources, and their experiences and their services are woven throughout all of our resources. So it very much hasn't just been a kind of an esoteric hypothetical exercise. All of the resources that we're going to talk to you about are absolutely rooted in the practice of not just occupational therapists, but the multidisciplinary colleagues who work alongside them in housing, health and social care settings. So what is the point? Why have we created what we have created? Well, I think it's pretty unarguable at this point that there is a very, very clear direct link between our health and our homes. There is rafts of evidence now that demonstrates that good homes are supportive of good health, and poor homes can often be the cause of or an exacerbation of poor health, and that's coming in it from all sorts of different angles. So if we accept that to be true, if we all agree, and I would imagine that all of you in this virtual room will agree, that health and homes are very much interlinked, it seems very puzzling that as a system we don't seem to have got to grips with that in a particularly meaningful way. We are all still banging the drum and championing the idea that we need to, if we want to get serious about improving people's health, we need to improve the places where they live. So clearly I work for the professional body for occupational therapists, so we began to think about, okay, well, what's the opportunity for OTs here? What is it that OTs are already doing, kind of quietly getting on with in a quietly brilliant way, often at a very local level? What is it that we can be doing more of? Are there things that we need to stop doing? Are there things that we need to start doing? So what is the opportunity for our profession? And the more we discuss that with foundations and members and other colleagues, the more we recognise that actually there's a heck of a lot that OTs already are doing, and can be doing more of. But as I said before, none of that is in isolation. It's very, very rare for OTs to work completely and entirely by themselves. We are generally embedded within teams or working alongside teams or consulting into teams made up of a really wide range of people with different professional backgrounds. So this isn't just about going OTs are the answer to everything. It's about saying that occupational therapists have opportunities to support their multidisciplinary colleagues to work differently. And that's what we pull out in the resources that we've developed over the last 18 months or so. So Rachel's going to talk much more about this, so I'm not going to go into any detail about the resources that we've actually created, but just to acknowledge that if we want to bring about change, if we want occupational therapists and their multidisciplinary colleagues to feel and able to work differently, that requires influencing and support at different levels. So at the kind of, in terms of the grassroots, in terms of the frontline work, we've created practitioner resources that will enable the OTs and their colleagues who are out there doing the doing to think a little bit differently and give them kind of practical things that they can apply in order to make shifts to their practice. And we're not saying that every single occupational therapist needs to be a housing specialist. Clearly there is a need for housing specialists, but actually there are things that every single occupational therapist in every area of practice can be doing to have more influence over people's health outcomes through where they live. So there's a whole suite of resources very much rooted in work that's already going on out there in the system that will help OTs and their colleagues to bring about change. But in order to create the conditions for that change, we need the people who manage those services and lead and develop and commission those services to be on board. So the operational toolkit very much speaks to that audience. And then the strategic document kind of wraps around all of that in terms of what are the national policy conditions, the regional policy conditions, the ICB discussions that we need to be having in order to support these shifts, be they small, be they large, be they local, be they regional, be they national. I've already said that as far as I'm concerned, it's basically inarguable that there's a link between our homes and our health. It is such a widely accepted social determinant of health. But that matters for people, it matters for us as professionals, but it matters for socially as well. When we started delving into the existing evidence and research about linking health and homes, the amount of money that is wasted every single year because we are not effectively addressing homes as a determinant of health is eye-watering. So there are various sources. We've got one of them up here, but you can read it for yourselves. Fixing England's dangerous homes. This is England alone, let alone the rest of the UK, but would deliver more than 1.5 billion in annual health and social care savings. There's another piece of research that we quote in the strategic report, which indicates that if you take into account all the wider societal impacts, such as access to education, access to employment, caring responsibilities, the total cost to society of poor homes every year is about 18.5 billion pounds every single year. Just think how much more effectively we could be spending that. I've got a whole list of things I could tell you that I would do with 18.5 billion pounds. So it's a societal concern that we're not getting to grips with this more effectively. The other thing that really sticks out to me from these particular quotes, and this is just a very small snapshot that I've put up here, but 3/4 of health workers see patients whose poor housing is likely harming their health. I would argue that for occupational therapists, that is much closer to 100%. I would defy you to find a single OT who at some point in their career hasn't worked with someone whose housing is affecting their health. So that feels pretty stark. But if we accept again that at least 3/4 of health professionals are working with people whose housing is affecting their health, that means that at least 3/4 of us have got an opportunity to do something about it. And that is very much what building health into homes sets out to achieve. I'm not going to dwell too much on this in terms of time, but I think it's important to say that one of the things that I've said over and over again throughout this project is that housing is every occupational therapist's business, because every single person that an OT works with lives somewhere. So when we talk about occupational therapy and housing, very often we're talking about OTs in specialist roles, and we are talking about OTs in social care. Now, those roles always have been and always will be incredibly important, but this is just a snapshot of why housing is just as relevant to the many, many, many occupational therapists who work in hospitals or who are employed by the NHS, because by some quite considerable margin, housing is the single largest cause of mental health discharge delays. Acute hospital housing delays tripled just in the space of 2 years. So this data is now a couple of years old. I would strongly suspect that those rates have increased rather than decreased. But all in mental health and acute physical health hospitals, the financial cost, the individual cost of discharge delays arising from housing is, again, pretty eye-watering. So that's just a bit of a snapshot of why, as occupational therapists, this isn't just a housing and a social care issue, but as a wider system, we need to be engaging with our NHS colleagues on this agenda. None of us can solve this alone. It's not just a housing problem. It's not just a social care problem. It's not just a health problem. It's a problem that we need to solve in the round, and OTs are uniquely positioned to be able to do that. I'm assuming that most of you in this virtual room will be very familiar with some of these statistics, but as Jeremy has already said, the focus within building health into homes isn't just about what occupational therapists can and are already doing in terms of home adaptations. It's very much thinking about the future housing stock and how we are already and how we could be having a greater impact upon the homes that don't exist yet. So making sure they're well designed, well located, that they're provided to the people who really need them upon completion. And why now? Why is now the right time? Well, there's been quite a lot going on politically. You may have noticed over the last couple of years, and this week even. But happily across the UK, so not just in England, but across all of the UK nations, there is this kind of consistent messaging around what the priorities for the health and care systems need to be. And it's very much about delivering more support to people out of hospital. So supporting people in their homes and communities, supporting them to stay well, so preventing illness and injury from happening in the first place. And there's also this real kind of digital component to do that. Now, if that's the priority of the health system, in my view, they will not achieve that in anywhere approaching a meaningful way if housing isn't front and centre. And these are just a few snapshots of why I feel so passionately about that. If we want people to live well at home, their homes need to enable that. We can't wait for people to have a crisis and end up in hospital before we intervene. I've already said this, so everyone lives somewhere. Every single person that an occupational therapist works with, that housing teams work with, that social care teams work with, lives somewhere. That might not be their own home. It might not be a home at all. So there are increasing numbers of occupational therapists and homelessness services, for example, but everybody lives somewhere. And as OTs, we are one of few professions who are already based in those three systems that have the most opportunity to have real impact in this agenda. So we're in housing. There are housing OTs in this virtual room. Rachel and I are two of them, and so is Lucy. But there are those of us who come from health and social care backgrounds as well. So we're positioned in the systems that we want to bring closer together, so we can be the glue that draws things closer. In terms of the occupational therapy opportunity, though, it's not just about where we are, it's also about how we think. So as OTs, as soon as we qualify, it's a really core part of our training and our professional philosophy that the built environment, the physical environment, the social environment has a huge impact upon how well we are able to live our lives, upon our day-to-day occupational performance, as we would put it. So we know all of this, and that's true whether you're a housing specialist, a social care specialist, whether you're in a neuro setting, whether you're working with children, whether it's adults, whether you're working with older people, it doesn't matter. Every single one of the over 40,000 occupational therapists in the UK has that core understanding of the impact that the built environment has upon people's health and their occupational performance. So we do have a very genuine, I think quite unique opportunity as a profession. I think the other really key thing that's come out of the Building Health into Homes project is that that occupational therapy potential isn't just about physical accessibility. Now, certainly when we talk about adaptations and even new build homes to a great extent, we're largely thinking about the physical accessibility and people's physical health and mobility needs. But OTs are doing brilliant work around supporting people with mental health needs, to maintain tenancies, to support people to transition out of acute inpatient mental health settings back into the community, and for that to be successful. There's ever increasing awareness of the impact that people's sensory environment has upon their well-being and their ability to thrive, be that because people are neurodivergent or because maybe they have cognitive challenges, dementia, for example. So it isn't just about the bricks and mortar, it's about the whole system of living within homes, and there's lots that OTs can do and are doing already about this, a lot of which is reflected in the resources within Building Health into Homes. I've already made this point, I'm not going to labour it. I haven't included housing and social care on here because it's blindingly obvious that the OTs in those settings can have an impact upon this agenda. But this is just a snapshot of the other areas where occupational therapists are already hidden in plain sight, where they could be having a much greater impact upon people's housing conditions and therefore their health outcomes. The final thing that I want to say, I've made the point about working collaboratively, but if nothing I say convinces you, if nothing that any of the other speakers today say convinces you that we need to be working more effectively together around health and homes, I urge you to read Martha's story in our practitioner toolkit. Martha is an expert by experience. She has been really generous with her time and her lived experience in helping us to develop the resources. She was a really crucial part of our steering group for the project, and she's experienced the good, the bad, and the ugly in her lifetime in terms of the support or lack of support that she's received from health, social care, and housing services. I'm delighted to say that she is now living in a home that absolutely meets her needs, and she has flourished as a result. Rachel and Chris and I have been privileged to know Martha now for well over 12 months, and to see her progress as a result of her housing because she's been supported by occupational therapists. It's genuinely remarkable. She is the proof in the pudding. So if you don't believe me, I defy you to not listen to her. That is her delightful assistance dog, Greg, who absolutely stole the show at the House of Lords a couple of weeks ago. So I am going to leave it there. I haven't had a clock on my screen for any of this, so I really hope I've not overrun too dramatically. You can probably tell I could talk about this all day, and sometimes do. But on that note, I will cease speaking and hand over to Rachel. for the next bit.
Well, before you do, Lauren, thank you very much. That was a really great overview of both the practical tools as well as the report. And I think while Martha couldn't be with us here today, I think Neil from Gloucestershire is with us. So I know how much you're working closely with Martha in the locality there. So good to see that you're on the call, Neil. So Rachel, you had a big introduction from me, but also from Lauren, a critical friend and partner of this project. So over to you.
Yeah, can somebody just give me the reassurance that my presentation is showing?
Yeah, that's perfect.
Yeah.
Lovely, thank you. Yeah, thank you, Lauren. Lauren's given an absolutely fantastic introduction to obviously the work that Foundations has been supporting RCOT with, and again, a huge thanks to Closemat for their support as well. So what we have done with RCOT is we have developed 3 toolkits, resources that support the why, the what, the how. So what I'm going to do over the next 10 minutes is just to go through each of the individual resources so that you, the audience here today, have an understanding of what is behind those resources, what is in those resources, and hopefully how you can use those resources to support the work that you do in and around housing. And I'm sure somebody will bob the link to the website where you can find these resources on the Royal College's website as I'm speaking. So the why. So the strategic resource is basically a strategic report for those that are in those positions where you're thinking about how do we make better use of occupational therapists in housing to support the many priority issues that we've got in and around housing. So it's an evidence-based document that sets out, and I won't go into each of these bullet points, we know these and Lauren has already spoken to these, but it sets out that evidence base around why health is such an important, or why housing is such an important part of health, and how housing is going to be instrumental in how we will address the health and well-being needs of older and disabled people over the next many decades. What the strategic report does, though, is draws all those kind of strings together and really explains how, I'm not saying OTs are the answer to everything, but we are unique because we are one of those allied health professionals that sits at that intersection between housing, health and social care, and actually how as a profession we can support housing, health and social care to come together to address some of the challenges, or the many challenges that we have, if we are ever going to ensure that housing really does support the health and social care needs of society. So that is what is in the strategic report. It sets that evidence base out and helps identify how occupational therapy is already doing a lot of this. I think we were very keen that we weren't trying to invent roles for occupational therapists. What we have done is amplified the work that is already being done out there by occupational therapists. So that's a little bit about the strategic toolkit. And then we've got the operational toolkit, which is what do you need to do? So the strategic toolkit has talked about how occupational therapists can support housing, but actually how do you do that? I think naively, when we set out on this project 18 months ago, I think we thought we would identify this single housing OT role. And I think through the work that we've done, through the must be over 100 OTs that we've connected with during the project, I think what we've realised through those interviews across the 4 nations, that actually what we've discovered is that there are 8 distinct ways that occupational therapist is supporting housing, health and social care, and can help housing to support the health and well-being of older people. So I think we naively thought that we would identify a single housing OT role, and this is what that role can do. And I think what we've established is that there are actually 8 roles that occupational therapists can support with the challenges and opportunities that housing have in terms of that integration agenda and that preventative agenda that Lauren has already spoken to. So the stuff around supporting new build, development, supporting strategy and planning with housing, asset stock management, supporting with housing needs assessment, the kind of bread and butter stuff that I think OTs are always associated with around adaptations, equipment, tenancy support and sustainment, supporting people with really complex needs, how we do that really good hospital discharge work when housing is an issue, and supporting training and system development around housing. So I've just popped this slide in because one of the things that obviously the strategic report did was highlight some of the kind of issues that housing has. And then what we've tried to do with the operational toolkit is show how to develop those OT roles that address those problems that and opportunities that we've got in housing. So yeah, I think that's just a useful slide to demonstrate and help you understand how those 8 OT roles that we can have in housing can support the issues that you have in and around and across housing. So basically, the operational toolkit is, what do you do to develop those roles? We've done the heavy lifting for you. So we've developed those 8 roles framework. We've got a huge amount of implementation case studies to show you how to do that. And those case studies are not only from England, but they're from across the 4 nations. We've got, one of the things that people were asking for is, we always need to put business cases together. So what you will find in there is business cases, templates to support 4 distinct roles. We've got job descriptions that people have kindly donated, if that's the right word. And also about gathering evidence as well, because to get these roles, we need to develop and show how effective they are. We need to develop the evidence. So there is some guidance there around how you measure the impact of these roles. So the operational toolkit is, what do you do? And it does that heavy lifting for you when you're developing these housing roles. And then we come on to the practitioner toolkit. And this is the bit about, how do we as OT start thinking differently? Lauren's already spoken about housing is every OT's business. Those of you that know me and the work that we did 6 years ago with Jeremy and Adaptations Without Delay is about making best use of our skills as OTs. But the thing that I always get exercised about is, we're all occupational therapists, but we need to avoid working in silos. So I think for me, the practitioner toolkit is, how do we as OTs think differently so that we all take responsibility, whether you work in end-of-life care to whether you work in social care, learning disabilities. Because what we don't want to do is be referring people on. And so it's about how we do that. So the practitioner toolkit, again, it's about using early conversations, and we've developed some really practical tools for practitioners out there so that all OTs can start thinking differently about those jobs and hopefully challenging some of the silos that we can see across systems. So one of the key things that we've done, Jill Pritchard, who's a fantastic OT up in Scotland, who was part of the team working on this project, developed this conversation toolkit that helps occupational therapists think about where are they working and how can they begin to have housing conversations. So we've got, as I say, the practitioner toolkit is about reframing OTs and housing being all OTs. Mentioned the conversational toolkit. One of the things we talked about was whether we were going to develop a competency framework, but anybody who's developed a competency framework knows it takes forever. And actually, we've done something a bit more novel and actually used the brilliant expertise of OTs that have already started this kind of journey as OTs working in housing to inspire the next generation of OTs. So we're delighted that I think we've got about currently, and we will be adding more, currently about 15, 16 pen portraits around real OTs that have got these variety of roles, as well as training resources, glossary of terms to help those that are less familiar with housing, the legislation framework, and lots of design resources as well, and links and bits and pieces. So that is what you will find in the practitioner toolkit. I've hopefully kept time. I could talk for hours, as just like Lauren, but I'll stop there because I'm sure we can answer some questions at the end. But hopefully that gives you just a flavour of what is in all three toolkits and resources.
Rachel, thanks ever so. Really impressive, again, building on what Lauren was saying, but you've again articulated and set out the framework, but also those three resources and how each of those contributes to really improving a better understanding about the role of adaptations. Before I hand over to Lucy, I was just wondering whether Chris wanted to say a word or two. And in particular, I noticed that the Foundations recently published a charter on adaptations aimed predominantly at social housing, and whether there's any lessons from what Lauren and Rachel have highlighted in relation to that, Chris.
Yeah, definitely. Thanks, Jeremy. Yes, yeah, I think there is actually. So just to give a sort of a brief overview of what this is, we held a conference with housing associations in particular in Manchester a couple of weeks ago. And at that conference, we launched the Home Adaptations in Social Housing Charter, which is basically 10 promises for local authorities and 10 promises for social landlords, practical promises, and mainly about things like better communication, clearer roles, timely decisions, shared information, and kind of a more consistent approach to consent and delivery. And what we're trying to get is for social housing providers and local authorities and OTs to sort of sign up to this. It's on our website. And so what I will do is I will put a link in the chat once we've finished this. But just to say name a couple of things on there that might be relevant to this conversation is one of the local authorities' promises to clarify OT client and designer roles, and there's something on there about assessments as well. So what I'll do is I'll put that link in the chat, Jeremy, and thanks for raising that.
No, really important point, and I'm sure it's something that Lucy and Tots will also be very relevant in terms of your client work and the engagement that you have across both householders as well as the funders and the commissioner. So that's probably a great segue back to you, Lucy, and thank you very much for your support. I'm sorry I couldn't meet you in person last week, but it was great to see some of your team at the House of Lords. So Lucy, over to you.
Thank you. Thanks, Jeremy. Okay, bear with me. There we go. Okay.
Right. You're ready to go.
I'm ready to go, thank you. The IT gremlins have disappeared, thank goodness. So thanks, Jeremy. Yeah, it's been really good this webinar. I've really enjoyed listening to Lauren and to Rachel. And Lauren set out sort of why housing has to be treated as part of health and care, and it was great that Rachel has taken us through the resources that can sort of help us act on that. But I want to spend my 10 minutes on sort of the practical questions. So how do we make this real in systems across the United Kingdom? Because the challenge for occupational therapists isn't that we're not joining housing with occupation and people. We're absolutely doing that. It's that we need to bring that expertise in early enough so we can actually influence outcomes. So I think what's happening too often is that occupational therapy is brought in after key housing decisions have been made. So the person may be already living in a home that no longer works for them. They might be waiting for a hospital discharge. They might be waiting for an adaptation, or they might be waiting to find out whether something is actually technically feasibly possible in their home. So basically, by that point, the occupational therapist becomes a response to a problem that's already escalated rather than addressing the problem in the first place. And we see this right across the system, and I can give you some examples. So like a bathroom that doesn't support safe washing, for example, means that we might have to increase somebody's care package, or they have to rely on care. And things like a bedroom in the wrong place or a toilet in the wrong place can affect things like sleep, family life, continence, dignity, risk. And for children and adults with sensory and cognitive needs, the home environment can either support regulation and safety, or it can actually add to distress and restriction. So I think one of the difficulties that needs to be addressed is that clinical, housing, and technical decisions often happen in separate parts of that pathway. So the occupational therapist will understand the person's occupational needs. Housing might understand the constraints of the property, and your surveyor and the contractor might understand basically how things can be delivered. But if the conversations are happening too late, it can result in delay and frustration for the people that we're working with. So I think the practical challenge with building health into homes is how do we bring occupational therapy reasoning into housing decisions early on enough to make a difference, rather than the occupational therapist responding to a problem. So one example of moving occupational therapy upstream was the work that the Occupational Therapy Service was commissioned to do with Newham Planning Department. And we were really fortunate to have 3 fantastic occupational therapists who led on this work. And basically this was about focusing on housing design needs for neurodivergent residents and residents with learning disabilities within Newham. And the important point for me was this is not an adaptations project. This wasn't about providing adaptations after an event. It was design guidance project to influence how homes are thought about before the residents are actually living with those avoidable barriers. And it was fantastic methodology. It brought together different strands of evidence. So the occupational therapist reviewed existing research around housing, neurodivergence, learning disability, daily occupation, sensory needs. And then the occupational therapist went actually into Newham and reviewed some of the housing schemes that were there. So the work wasn't desk-based. The occupational therapists were out in the field looking at the housing stock. So they were looking at things like the layout, acoustics, lighting, outdoor space, which is often overlooked, I feel, and safety and people's ability just to undertake their daily routines. And a central part of the work that was done was about engagement. So we listened to residents, we met with residents and spoke to them about how their home was stopping them from living their lives, from carrying out their daily routines. So it might have been the way noise travels in a home. It might have been around the visibility of an exit for somebody who's at risk of leaving the home unsafely, or whether a parent can supervise a child with additional needs during the night. So our role as occupational therapists was to take that evidence, so the lived experience of people, the feedback and the evidence, and translate that into design guidance. So it wasn't about saying people need better housing, but it was what better housing needs to consider, basically. So how does the environment support regulation? How does it reduce risk without becoming restrictive? And how does it allow family life to exist? So the final design guide wasn't a clinical assessment report. It was actually occupational therapy helping planners, housing colleagues, designers, developers understand the relationship between the built environment and everyday function. And I think it really allowed the importance of occupational therapy to shine. And that's a really good example for me of moving occupational therapy upstream. So we're used to understanding the person and the environment and occupation together, but there was an opportunity there to bring reasoning into housing decisions rather than just adapting around problems that had already happened. And I find that occupational therapists often talk about adaptations as though they're a product or an installation. And I really feel that adaptations are clinical, technical, but they are also human. So if you think about a level access shower or a ramp or a stair lift, it's not just a piece of equipment. It changes how somebody washes. It may change how they leave the house. It may change how they feel about being safe in their own homes. And that's why a good recommendation has to do more than just identify a solution. It's got to be clinically reasoned, but it's also got to be technically deliverable. So it's not enough just to meet the person's occupational needs. And it's interesting that Chris touched on the Housing Adaptations Conference in Manchester, because I found there, the social housing conference, that everybody in the room knew that the adaptations were important. That wasn't the question. I think the frustration that I had conversations about was the number of handoffs in the system. So the occupational therapist would go in and do an assessment, then the surveyor would go, and then there would be possibly landlord consent, specification, quotes, funding, installation, checking. And these things happen in sequence rather than together. Another example of sort of bringing that together and reducing delay is our partnership with AKW. That we basically have this partnership where we go in, do the occupational therapy assessment and all of the technical recommendations and the drawings and everything is done there and then, rather than handing it through the system. And it's not about replacing local authority OTs or housing OTs, but it's a good example of how collaboration can reduce delay and reduce duplication and keep the person's occupational needs very closely aligned with the technical parts of the adaptation. Okay, so if we are serious about building health into homes, and I hope we all are, I think there's 3 practical things that we need to do. So we need to bring in occupational therapy earlier, not when somebody's already in crisis or when an adaptation's been requested, but we need to think about occupational therapy in planning, design, housing allocation, commissioning, pathway design. That's where occupational therapy reasoning can help prevent problems rather than just respond to them. The second is about measuring outcomes beyond just their completion. So I feel really strongly that it's not just okay to say that an adaptation was installed, a case has been closed, it's been ticked off, an assessment was completed. We need to stay connected to that occupational outcome. So can the person wash safely? Can they get in and out of their home? Has the care package been reduced? Can a child be safer in the garden? Can a parent sleep, work, care, participate in family life again? Can somebody participate in activities of daily living in the kitchen? So that's really important. It's not about ticking a box. And the third thing is around the person. Residents, families, occupational therapists, housing teams, surveyors, contractors, commissioners, we're all trying to solve the same problem, but we're doing it from different parts of the system. And I feel when the conversations happen too late, the pathway's slow and it's frustrating for everybody. But for me, building health into homes almost gives us that permission to talk about housing as part of health, care and occupation. And I feel that the home can either support dignity and participation, or it can create risk and restriction. So occupational therapy, as ever, has something really practical to offer, but we need to place the expertise earlier, connect it better, and judge the success of an adaptation by the difference that it makes to people's everyday lives. If anybody wants to discuss further, my contact details are there, but obviously there may be questions in the chat box, and I've really tried to stay to time.
Lucy, you've done more than that, and I think I really love the way you sort of drew that to a conclusion, because while you were talking about some of the system issues, your overarching message right at the end was very much around the value and the impact and the outcomes for individuals, and making sure that that's right at the centre of an integrated adaptations approach. So thanks ever so much for that really well set out presentation. And I know that Rachel has put something on the Newham example in the chat, and we're looking forward also to showcasing, I think, your Derby work as well in the months to come as well. So that's brilliant.
Thank you.
Now we've got a couple of questions, which is great, and thanks ever so much for that. Before we do go into those, I'm just struck by all your presentations, that the link, just not with practice but also with policy, and that building the case, is very much at the heart of the Casey Commission. The work that she has singled out around MND, motor neuron disease in particular. I think that really reflects both that sort of points that you were talking about, Lucy, around the pathway, but also that Neil raised in the chat around accessible housing registers and beyond. And I suppose my question first, before I come to Jackson, Neil, are, what is the role, not just of OTs, but the broader system around the role of home improvement agencies or good homes hubs and the like? And do you see there a natural fit to think where the role of OTs fits into adaptations, but also potentially advice, information, community equipment, technology, and other sort of housing options support as well? So could I kick off with you, Rachel and Chris, and perhaps then come to Lucy and Lauren on that?
I'll step in. Sorry, Chris. Yeah, I think you're right, Jeremy. I think it is about recognising, and again, it's. I mean, I'm just thinking about the one of the housing publications she probably did about 15, 16 years ago about that integration. But it does feel now, obviously, with the work that Casey is doing, the fact that the agenda around neighbourhood health, and that does feel like there is now that shift around getting services out into the communities and supporting people. And it's about ensuring, whatever we call them, home improvement agency, good home hub, it is about having that housing offer around the range of advice and support that older and disabled people need. And a good home improvement agency provides, again, the skills, knowledges and services that will enable people to come home. It's all very well and good shifting kind of hospital services out into the communities, but if we haven't got the right home environments and support, people aren't getting the right advice around how their health can facilitate their health and well-being, then none of this is going to work. But it's not just about OTs, it's about the knowledge and skills that housing colleagues also have, around supporting people to think about moving on. So they're going to be vital if those community models, that shift is actually going to work. But I know we've been saying it for years, but it does feel, and whether I'm being naive, Jeremy, but it does feel that there is a real shift in the tide around actually making this actually work now.
I think with the new Prime Minister, who's been in Manchester very much focusing on integration and across the combined authority, that may also lend some sort of support, both moral support, but also some tangible physical support as well. Chris, Lauren, Lucy, any thoughts on this in terms of the broader market and the broader interventions?
Yeah, there was something that struck with me. So interestingly, a colleague from the MND Association spoke with Rachel and me and Jill Pritchard, who's one of the co-authors of the project, a webinar last week, and they're really supportive of the work as well. And I think it's that, coming back to what I was saying about, we all understand that homes are an issue, so why aren't we working collectively together? But one of the parts of the toolkits that she singled out was in the practitioner tool, we've got an early housing conversation framework that Rachel mentioned, which is aimed at occupational therapists, but there is absolutely no reason why it couldn't be used by other colleagues who are supporting people to address their homes and their health. And it's just sort of pretty straightforward, kind of simple kind of prompts and questions that people can use to start a conversation. And I think sometimes people think, you have to have the solution in order to ask the question, but actually just asking the question and knowing where you can signpost people to is really, really important. And I think kind of not assuming that someone else will do it kind of accepting that we all have an opportunity to have real impact, and the early housing conversation can be part of that, regardless of what condition it might be that someone's living with. But certainly, obviously, with a life-limiting condition like motor neurone disease, it's incredibly important that we all take the opportunities we have to make things easier for people. Yeah.
Lucy, any thoughts, or Chris?
Sorry, Lucy, go first.
Okay.
No, go
on. We've got a number of projects around the UK that we're working on, assessing people in their own homes for adaptations. And I think one of the frustrations that I come across is colleagues in commissioning and those that hold the purse strings see adaptations as expensive. And adaptations are not expensive. They have a fantastic return on investment, because, as we've said in this webinar so many times, that homes are so closely linked to health. And for people to remain healthy and remain at home, we need to invest in their homes. So instead of thinking of an adaptation as being, over budget or too expensive, can we do something cheaper that's not going to work in the long term? And I appreciate, we haven't got an unlimited budget, but just the education around the return on investment in housing, and if we can speak about that at every opportunity. I've had a conversation about this today with one of our associate occupational therapists, where she was told something was too expensive, and that's what the person needed because of the postural needs. Won't go into details, but yeah, so that would be my I suppose that would be something that I've picked up over the UK.
Thanks. Chris, you had something to say?
Yeah, just very quickly, I was just going to bring, you mentioned policy in your question, Jeremy, and we're about to enter one of the biggest changes to the local government landscape in 50 years with local government reorganisation. And I think that with a lot of occupational therapists who work in adaptations will be based within county, will be based within those structures, which may be broken. Which will be broken down in some places. So there's a lot of uncertainty there. But I think that what building health into homes does, it's almost LGR proof, because it's about skills, and it's about talking to people, and it's about listening as well. And look at Martha. I thought it was great that you brought Martha into it, Lauren. And because you listened, Martha got a great outcome in the end, although it wasn't plain sailing. So I think it's in that context, I think it's great timing for this to be out.
Well, you mentioned Martha, and Anil has asked a question. Yes, we will be sharing the slides, all the slides, and a recording later this week, Neil. So hopefully that will be in time for your meeting. And I know, talking to Martha myself last week, she's really keen to articulate and build on the experience of working with the RCOT and the Foundations and the team about her and Greg's experience. And watch this space. It could be a joint blog in the future. But I want to come back to Jax's question. We come back to the Q&A box, and Jax raises a really important issue about exclusion and in this particular case around sight or dual sensory loss. And I know Sheila Peace, who's on the call, was one of the investigators for the recent Amarbari project around the Bangladeshi community. And again, within there was an issue about groups that were marginalised and excluded often, or felt excluded from adaptation process. And Jax, you helpfully sort of highlight the very low numbers of confidence in terms of utilisation of services. And I'm just wondering whether the team had any thoughts around that. I mean, the Housing Lin has got a dedicated page on sight impairment and built environment. And I think Foundations did a report with Poplington many years ago as well. I don't know whether Rachel and Chris were around in those days, but I'm sure you know it well.
That's a very old publication.
It's a shame, my age now.
But just kind of making that link in terms of making that link to the tools that we've developed. It's that role that occupational therapists can help in terms of helping housing colleagues get a better understanding around, because obviously as OTs we're not just as Lucy has identified, we're not just interested in kind of physical disability, but we look at the range of impairments, whether they're some sensory, cognitive, communication impairments. And I think that's where OTs can support with training housing colleagues around that. And again, we've got examples around how some OTs are supporting housing colleagues around that, so they have that better understanding. And I think the thing that I've learned, because one of the questions I asked all the OTs that I had conversations with, what is it that OTs contribute to housing? What is it? How is it? What is it that is different about our role? And I think it is this bit, and I'm not the first person to say it, but it's about how we can translate kind of accessibility standards and the whole gambit, but it's about how we have as OTs and that understanding about actually how people are able to use their environment and how people live their lives in their home environments. And I think we can translate that in a way that housing colleagues understand, whether they're a surveyor, whether they're a housing officer. I think we're good at being able to articulate that as OTs, being able to turn that access bit into actually how people use their homes and help them and provide that training bit.
Brilliant. Any other comments around that sort of broader exclusion and points, Lauren?
Yeah, I think I can completely agree with what Rachel has said, but I think the kind of the project that Lucy's outlined is a good example of why it's often really important to take a local perspective. So kind of really start by understanding your locality, your local authority, your local population, and collaborating with people. And again, Martha is an excellent example. There's so much that wouldn't be in these resources if Martha hadn't shared her lived experience with us. So there's definitely something about engaging purposefully and intentionally and early with the very people who you're aiming to support. And of course, I agree that occupational therapists are ideally suited for that. And again, Lucy's example is really great, because what they've achieved in Newham, it's not that it's not necessarily that you can automatically lift and shift it to other parts of the country, but there's certainly learning that can be transferred and scaled elsewhere. I think just to talk about the operational toolkit as well, which is focusing on how do you implement these kinds of changes at a system level, local system level or a regional level. And we've got business case templates in there which demonstrate how you can draw on occupational therapy expertise. It doesn't necessarily mean that you have to employ an occupational therapist permanently in a constant role. Obviously, we would love it if people did, but actually that's not always what's needed, and that's not always what's most valuable. So contracting occupational therapists in, like the work that Lucy and colleagues do and other independent occupational therapists and OTs in private practice do, is really important. If you've identified a local need, there will be an OT out there somewhere who can support you with it. They might not be based in your social care team, they might not be based in your housing team, they might be working in your hospital. But I think that's the whole point about this being a cross-system issue, is that, and I've said it already, but OTs are very often hidden in plain sight. So there will be an OT out with the expertise out there who can support whatever it is that you're trying to achieve. It's about locating them and then bringing them into your service in the way that's going to work for you. So that's definitely what we've tried to provide the tools for with the project.
Well, on that note, can I thank you all for fantastic presentations. Thanks for everybody for their questions, and for others who've posted other useful resources. So Jagal has put something about neurodivergent toolkits. Can I also draw attention to the Inclusion London guide on accessibility and adaptable homes that looks at issues around deafness as well, coming back to that sensory loss. But I hope you all agree it's been a fantastic set of presentations by Lauren, Rachel, Chris and Lucy. Can I thank you, and also Jerome and Chris behind the scenes for your support. If this is the first time you've joined us, I regret to say that next week is our final happy hour of our current series. We will be resuming in the autumn, around late September. But if you are interested in supported living and supported housing, we're going to put the Supported Housing Regulatory Oversight Act under the spotlight next week with Sir David Nicholson, who is chair of the group leading the implementation of that, and others who are sort of designing training, managing and supporting people with a lived experience around learning disability and people with autism around their care and support needs. But that leaves me just to say we'll be circulating the slides shortly and the copies of the presentations. Please do complete the feedback form, and we look forward to either joining us next week at our final happy hour of the series, or in September when we resume our autumn and winter programme. Have a good evening. Thanks, everybody.
Thanks.